Good afternoon everyone, I'm Dr. Swati Singh, Associate Professor, Department of Pathology. I'll be talking about ischemic heart disease. These ischemic heart disease represent a group of pathophysiologically related syndromes which result from myocardial ischemia, which is an imbalance between myocardial supply and perfusion and the cardiac demand for oxygenated blood. Ischemia not only limits tissue oxygenation and thus the ATP generation, but also reduces the availability of nutrients and the removal of metabolic wastes. In more than 90% of cases, myocardial ischemia results from reduced blood supply due to obstructive atherosclerotic lesions in the epicardial coronary arteries. Consequently, ILD is frequently referred to as coronary artery disease. Thus, ILD is often the late manifestation of coronary atherosclerosis that began during childhood or adolescence. The clinical syndromes included in this are myocardial infarction, angina pectoris, chronic ILD with heart failure, and sudden cardiac death. Myocardial infarction is a scenario where there is ischemia causes frank cardiac necrosis. Angina pectoris, literally known as chest pain, where there is ischemia is not severe enough to cause infarction, but the symptoms nevertheless portend the infarction risk. Epidemiology: ILD is the leading cause of death in the United States. 1 of 6 every 6 deaths in 2008. More than 400,000 individuals, that is more than 400,000 individuals, and under developed nations, which is approximately 7 million total per year. Since peaking in 1963, the overall death rate from ILD has fallen in the United States by approximately 50%. The remarkable improvement can be attributed to earlier prevention and various diagnostic and therapeutic advances which allow earlier and more effective treatment. The pathogenesis: the dominant cause of ILD syndromes is insufficient coronary perfusion related to the myocardial demand. In the vast majority of cases, this is due to chronic progressive atherosclerotic narrowing of the epicardial coronary arteries and variable degrees of superimposed acute plaque changes which can be thrombosis and vasospasm. Manifestations of coronary atherosclerosis are generally due to progressive narrowing of the lumen leading to stenosis, which is fixed obstructions, or to acute plaque erosion or rupture with thrombosis, all of which compromise blood flow. A fixed lesion obstructing greater than the coronary chronic vascular lesion. More than 90% of patients with IST have atherosclerosis involving one or more of the epicardial coronary arteries. The clinical: 75% of vascular cross-sectional area defines significant coronary artery disease. This is generally the threshold for symptomatic ischemia precipitated by exercise, typically manifesting as angina. The acute plaque changes that can be associated: acute coronary syndromes are typically initiated by an unpredictable and abrupt conversion of a stable atherosclerotic plaque to an unstable and potentially life-threatening atherothrombotic lesion through rupture, superficial erosion, ulceration, fissuring, or deep hemorrhage. These plaque changes, typically associated with intralesional inflammation, precipitate the formation of superimposed thrombus that partially or completely occlude the artery. The consequences of myocardial ischemia include stable angina, unstable angina, myocardial infarction, or sudden cardiac death. Stable angina results from an increase in myocardial oxygen demand that outstrip the ability of the stenosed coronary artery to increase the oxygen delivery. It is usually not associated with plaque destruction. Unstable angina is caused by plaque destruction that results in thrombosis and vasoconstriction and lead to severe but transient reductions in coronary blood flow. In some cases, microinfarctions can occur distal to the disrupted plaques due to thromboemboli. Myocardial infarction is often the result of acute plaque changes that induces an abrupt thrombotic perfusion resulting in myocardial necrosis, while sudden cardiac death may be caused by regional myocardial ischemia that induces a fatal ventricular arrhythmia. Angina pectoris is characterized by paroxysmal and usually recurrent attacks of substernal or precordial chest discomfort caused by transient, which is 15 seconds to incidents myocardial ischemia that is insufficient to reduce myocyte necrosis. There are three overlapping patterns of angina pectoris caused by various combinations of decreased perfusion, increased demand, and coronary arterial pathology. These can be stable or typical angina, principal or variant angina, or unstable or crescendo angina. Stable or typical angina is the most common form of angina. It is caused by an imbalance in coronary perfusion due to chronic stenosing coronary atherosclerosis related to myocardial demand, such as that produced by physical activity, emotional excitement, or psychological stress. This is described as a deep, poorly localized pressure, seizing, or burning sensation like in dilation, but unusually as pain and is relieved by rest, or administering vasodilators such as nitroglycerin and calcium channel blockers. Principal or variant angina is an uncommon form of episodic myocardial ischemia. It is caused by coronary artery spasm. The angina attacks are unrelated to physical activity, heart rate, or blood pressure. Principal angina generally responds promptly to vasodilators. Unstable or crescendo angina refers to a pattern of increasingly frequent or prolonged, which is usually more than 20 minutes, or severe angina or chest discomfort that is described as frank pain, precipitated by progressively lower levels of physical activity or even apnea at rest. Approximately 1 of the patients with unstable angina have evidence of myocardial necrosis. For others, acute MAI may be imminent. Myocardial infarction is also referred to as heart attack. It is the death of cardiac muscle due to prolonged severe ischemia. The incidence and risk factors associated with myocardial infarction. This can occur at virtually any age. Nearly 10% of myocardial infarcts occur in people younger than 40 and 45% occur in people younger than age 65. Nevertheless, MI frequency rises progressively with increasing age. Through middle age, male gender increases the related risk of MI. Women are generally protected against MI during their reproductive years. However, postmenopausal decline in estrogen production is usually associated with accelerated CAD, and ILD is the most common cause of such events. The pathogenesis includes coronary arterial occlusion. The following sequence of events likely underlie most MIs. A coronary artery atheromatous plaque undergoes an acute change consisting of intraplaque hemorrhage, erosion or ulceration, or rupture or fissure. When exposed to subendothelial collagen and necrotic plaque contents, platelets adhere, become activated, release their granule contents, and aggregate to form microthrombi. Vasospasm is stimulated by mediators released from the platelets. Tissue factor activates the coagulation pathway, adding to the bulk of the thrombus, and within minutes the thrombus can expand to completely occlude the vessel unit. The myocardial response. Coronary artery obstruction diminishes the blood flow to a region of the myocardium, causing ischemia, rapid myocardial dysfunction, and eventually, with prolonged vascular compromise, myocyte death. The anatomic region supplied by that artery is referred to as the area at risk. The outcome depends predominantly on the severity and duration of flow deprivation. The approximate time of onset of key events in cases of ischemic cardiac myocytes. There is onset of ATP depletion within seconds, with the loss of contractility in less than 2 minutes. ATP is reduced to 50% of normal in 10 minutes after the acute event and to less than 10% of normal after 40 minutes of the acute event. Irreversible cell injury sets in 20 to 40 minutes, while microvascular injury takes more than 1 hour to develop. The early biochemical consequence of myocardial ischemia is the cessation of aerobic metabolism within seconds, leading to inadequate production of higher energy phosphates, example creatine phosphate and adenosine triphosphate, and accumulation of potentially noxious metabolites, example lactic acid. Ultrastructural changes including myofibrillary relaxation, glycogen depletion, cell and mitochondrial swelling, also develop within a few minutes of the onset of ischemia. Early manifestations of ischemic injury are potentially reversible. Severe ischemia, which is blood flow from 10% or less of normal, lasting for more than 20 to 30 minutes or longer, leads to irreversible damage and necrosis of cardiac myocytes. This provides a rationale for early rapid diagnosis in acute MI to permit early coronary intervention to establish reperfusion and salvage as much at-risk myocardium as possible. The patterns of infarction, these can be transpleural infarction, subendocardial or non-transpleural infarction, or multifocal in microinfarction. Transpleural infarction, the necrosis involves virtually the full thickness of the ventricular wall in the diffusion of the affected coronary artery. This pattern of infarction is usually associated with a combination of chronic coronary atherosclerosis, acute plaque changes, and superimposed thrombosis. Subendocardial or non-transpleural infarction typically involves roughly the inner third of the ventricular wall, can occur as a result of plaque destruction followed by a coronary thrombus that becomes lysed before myocardial necrosis extends across the full thickness of the wall. Multifocal microinfarction, this pattern is seen when there is pathology involving only smaller intramural vessels. The gross and microscopic appearance of an infarct depends on the duration of survival of the patient following the MI. Areas of damage undergo a progressive sequence of morphological changes involving typical ischemic coagulative necrosis, the predominant mechanism of cell death in MI, although apoptosis may also occur. This is followed by inflammation and repair that closely parallel responses to injury in other tissues. Early morphological recognition of acute MI can be difficult, particularly when death occurs within a few hours of the onset of symptoms. The histopathological changes, typical changes of coagulative necrosis become detectable in the first 6 to 12 hours. The necrotic muscle elicits acute inflammation, most commonly between 1 to 3 days post an event. Thereafter, macrophages remove the necrotic myocytes, most noticeable 3 to 7 days, and the damaged zone is progressively replaced by the ingrowth of highly vascularized granulation tissue, most prominent at 1 to 2 weeks. As healing progresses, this is replaced by fibrous tissue. The clinical features: MI is diagnosed by clinical symptoms, laboratory tests for the presence of myocardial proteins in the plasma, and the characteristic electrocardiographic changes. Patients with MI classically present with prolonged, more than 30 minutes chest pain, described as crushing, stabbing or squeezing, associated with a rapid weak pulse. Profuse sweating and nausea and vomiting are common. Dyspnea due to an impaired contractility of the ischemic myocardium and the resultant pulmonary congestion and edema is a frequent symptom. The laboratory evaluation of MI is based on the measuring of the blood levels of proteins that leak out of the irreversibly damaged myocytes. The most useful of these molecules are cardiac-specific troponins T and I and the MB fraction of the creatine kinase. The MB form of creatine kinase with the CKMB is sensitive but not specific, since it can also be elevated after skeletal muscle injury. To summarize, time of elevation of CKMB, CTNT and CTNI is 3 to 12 hours. CKMB and CTNI peak at 24 hours, while top T levels peak somewhere between 12 to 48 hours. The complications of myocardial infarction include contractile dysfunction, arrhythmias, and myocardial rupture. Contractile dysfunction, some degree of left ventricular failure with hypotension, pulmonary vascular congestion, and interstitial pulmonary transuderates. It can progress to pulmonary edema and respiratory impairment. Arrhythmias, myocardial irritability and/or conduction disturbances following MI that lead to potentially fatal arrhythmias, and myocardial rupture. These include rupture of the ventricular field wall with hemopericardium and cardiac tamponade, rupture of the ventricular septum, which is less common, leading to an acute PSG and left to right shunting, and capillary muscle rupture, least common, resulting in acute onset of severe mitral regurgitation. So complications of MI to summarize can be ventricular aneurysm, pericarditis, infarct expansion, middle thrombus and pulmonary muscle dysfunction. Chronic ischemic heart disease describes progressive congestive heart failure as a consequence of accumulated ischemic myocardial damage and or inadequate compensatory responses. In most instances, there will be prior MI and sometimes previous coronary arterial interventions and or bypass surgery. Morphology: chronic ILD have cardiomegaly with left ventricular hypertrophy and dilatation. Invariably, there is some degree of stenotic coronary atherosclerosis and scars representing peeled infarct are usually present. Microscopic findings include myocardial hypertrophy, diffuse subendocardial vascularization and fibrosis. So that was to summarize the ischemic heart disease, both the acute, which includes myocardial infarction, angina pectoris, and the chronic atherosclerotic heart disease, chronic ischemic heart disease. Thank you so much.